Hello and welcome. This is Mrs. Fenton from Stevenson High School in Lincolnshire, Illinois, and welcome to our second virtual lesson. I wanted to let you know that myself and Dr. Swope, who you'll meet next week, will be running daily lessons on this YouTube channel for the College Board through May 1st. And you will meet Dr. Swope early next week. Each of these lessons are going to be between 25 and 45 minutes in length, and if you can't watch them live, they are being recorded. So we did this yesterday, but I'm going to go over it real quickly again with an overview of the 2020 exam. We'll let you know kind of what is happening today and in the next coming days. So as you know, this year's AP Psychology exam will be given entirely online, and it will be free response only. There is no multiple choice on the 2020 exam. Additional details about these FRQs are going to be released April 3rd by the College Board, and myself or Dr. Swope will be sure to keep you informed. Also looking at the exam for this year, so AP Psychology has 9 units, but only the first 7 will be covered on this year's exam. Today and tomorrow, we're going to be covering topics mainly from Unit 8. Colleges have asked that students, even if these are not on the exam, are exposed to these topics. Colleges are supporting AP students this year by allowing this more flexible exam with less content, but in turn, they have asked us to assure that students learn the material. To make these sessions really relevant to you in the upcoming exam, I'm also going to include some exam prep, and I'm going to make as many references as possible to the earlier units. Starting on Monday, though, we're going to start right in with Unit 1, and we're going to go through each of the units 1 to 7 in detail. Certainly not as much detail as your teacher in class, but we're going to cover them to the best of our ability. And a full schedule of what's going to happen on each day will be posted so you can prioritize the lessons you need to view. Today we're going to start with a little bit of a review of FRQ. We're going to go over the practice FRQ from yesterday, and we're going to talk today a lot about Unit 8 and reference earlier units, including Unit 1, History, Research, and Perspective, certainly Unit 2, Biological Basis of Behavior, but also Motivation and Personality. So to get us started, have to switch presentations real quickly. Thank you for hanging in there with me. I had the wrong presentation up briefly. Okay, so this makes a little bit more sense about today's lesson overview. Okay, the warm-up for today is actually yesterday's AP exam practice, so thank you for bearing with me with that for a minute. Researchers have designed an experiment to investigate the effects of a new medication for treating depression. So here we have part A and part B. Hopefully you remembered from yesterday to incorporate SODAS. That would mean that you would space your answers out, so there'd be a few lines of blank space between your part A and your part B. You answered them in order, a little bit easier when there's only 2 points. Included a short definition, applied to the scenario by answering the specific question and checking for synonyms. So for part A, the term was random assignment. And random assignment involves putting participants into either the control or the experimental group by chance to reduce confounding variables. The application would be that the response has to refer to minimizing the impact of the subject variables. So it's basically what random assignment does. The reason why you would use it is that it establishes control. So placing participants into group by chance allows it to be that the only difference between the two groups, of course, is the independent variable. You want to also be careful with synonyms with a term like random assignment. You don't want to say something simply like participants were assigned to groups randomly. So you would want to explain what that means. So being placed into the two groups, and whenever you see the word random, that means in this case probably by chance. So you have random assignment in an experiment where participants are placed by chance randomly into either the control or the experimental group. And you also have this process earlier in the research design of random selection, in which participants are taken by chance from the population to take part in the sample. Part B, you had serotonin, which is a neurotransmitter, and we talked about it in its relationship with mood in terms of things like depression. So your application needs to include how, in this particular study, they would be creating medications that would hopefully reduce depression by elevating serotonin levels. And that would, of course, increase mood. And again, remembering to use SODAS. So just a quick wrap up of free response question tips. No intros or conclusions, no thesis statement, and follow the SODAS acronym. Okay, for today, we're going to be talking about psychological perspectives and the etiology or the causes of disorders. And then we're going to go into a few more categories: feeding and eating, substance and addictive, and personality. And finally, we're going to end with a little bit of an introduction to treatment of psychological disorders. What I'd like to put up here for you real quickly is a study at home tip. So if you're at home studying for the AP Psych exam and you need a definition and maybe you can't find it in your textbook, or you want to see it written in a different way, the American Psychological Association, the APA, has an online dictionary, which should have every possible term you might be wanting to look up. Okay, now we're going to start talking about psychological perspectives and etiology, or the causes of disorders. Here are your 7 modern approaches or perspectives. And I want to start with the definition of psychology, which is psychology is the scientific study of the behaviors and mental processes of animals. And psychological disorders are essentially a collection of behaviors and mental processes. So today we're going to look at the causes of mental illness from each of these perspectives. So if you wanted to think about the cause of depression and you ask someone from the biological approach, they would give you a very different answer potentially than somebody from the psychoanalytic approach. Now I'd like you to take a look at this list of approaches and think back over the year. Can you name a psychologist from each of these 7 theoretical approaches or perspectives? They don't have to be associated with, mental illness and treatment with clinical psychology, although there are some relevant ones there as well. I'm going to give you a moment to try to, think about the course as a whole, and can you name a psychologist that would fit best under each of these approaches? Okay, let's see how you did. Psychoanalytic, I hope that the first person that came to your mind was Sigmund Freud. If you just finished the personality unit, then you would have spent a lot of time with Sigmund Freud's theory. Carl Jung and Erik Erikson are also names from the personality unit as well. And they are what we call psychodynamic, or sometimes called neo-Freudians, because they expanded on Freud's theory and his ideas. The behaviorism approach was studied in depth in the learning unit, and maybe you remember John Watson and classical conditioning of fears and his little experiment with little Albert, and B.F. Skinner with operant conditioning. Maybe you came up with some other names from the behaviorism chapter, like Ivan Pavlov. From the humanistic approach, again, 2 names that you may have heard about in the personality unit, Abraham Maslow with his hierarchy of needs, and Carl Rogers. The cognitive approach, we of course had an entire unit on cognitive psychology, but maybe you remember Edward Tolman and latent learning, certainly Piaget's theory of cognitive development. Now, Albert Bandura is a little bit different. You may have first read about him in the behaviorism section when you were in the learning unit with his observational learning theory and the Bobo doll experiment. But his theory is more than just, what a strict behaviorist would look at. And it's what we call social cognitive, because he does incorporate some social and certainly mental processes in his approach. We definitely have some names from the biological section. Evolutionary, you'd probably want to go with Darwin. And the sociocultural approach is from the social psychology unit, which we're going to discuss at some point during the time before the exam. Also, I just kind of want to point out to you that the term approaches or perspectives, they are essentially synonymous. You can use them interchangeably. And your textbook may use one as opposed to the other. So the College Board and the Learning Targets, they kind of use both terms. You may also have seen a term called schools of thought, which would also apply here as well. Although sometimes the expression schools of thought is used to refer more to the historic approaches, the structuralism, functionalism, and Gestalt. I want to point out that if you receive an approach or perspective on an FRQ, that you want to kind of start out by approaching it from the definition of psychology. So if they're asking you to explain a behavior like why would you take a class or try out for a sport, or in the case of Unit 8, what would cause a psychological disorder, you want to reference that definition of psychology. So psychology is, again, the scientific study of the behaviors and mental processes of organisms. So the biological approach would explain behaviors and mental processes, including disorders such as depression or anxiety or schizophrenia, as being the results of physiological factors. And there's a variety here. It could be differences in brain structure or function. It could be neurotransmitters. It could be genes. If you're looking at the psychoanalytic approach, I gave you 3 examples here that would score. So thinking back to that personality unit and Freud's theory. Anxiety disorders, from Freud's perspective, might be the result of unresolved unconscious conflicts. They could be fixation in an early psychosexual stage. It could be in terms of his personality theory, where the ego part of the personality is, unable to kind of balance the conflicting demands of the id, which operates on the pleasure principle, and the superego operating on the morality principle. So if you look at each correct example here, there's specific references in psychological terminology. And this is also illustrating how the concepts that you learned in the personality unit apply to Unit 8 as well. Okay, I'm going to have you try it yourself with the behaviorism approach. So if you're thinking about anxiety disorders, maybe a phobia, how would Skinner potentially explain that? How does he explain behaviors in general? And remember that while strict behaviorists like Skinner did not believe that psychology should study cognition, mostly because they felt it wasn't observable and measurable, modern versions of behaviorism, like Bandura's social cognitive theory, do incorporate the importance of thought. So I'll give you a moment to write out how behaviorists would explain anxiety disorders. Okay, so there's a couple ways you could have gone about, well, actually there's more than 2, but the first one I put up here is kind of looking at how Watson might explain it. So phobias, like all behaviors, are learned, and this would be learned through involuntary associations, potentially created through classical conditioning. Or if you're looking at it more from an operant conditioning perspective, that learned associations are the result of punishments or reinforcements that occur after behaviors that would either increase the behavior in the future, a reinforcement, or decrease it if it were a punishment. So now I'd like you to think for a moment about how classical conditioning creates phobias. Maybe think back to John Watson's Little Albert study. If you look at John Watson's study for little Albert, he showed that classical conditioning could be used to create a fear in an individual. And when I'm thinking about classical conditioning, I like to always look at the responses first, because the two responses, both the unconditioned response and the conditioned response, they're going to be the same or similar if classical conditioning happened, if learning occurred. And they're both going to be involuntary. So it could be an involuntary physical reaction, like with Ivan Pavlov, with the salivation. It could be blinking, shivering, but it also could be an emotion. So there's a involuntary physiological change that's also associated with an emotion. So now when you look at something that's unconditioned, remember condition means learned. So if it's unconditioned response, it's an unlearned reaction. So what was it that Watson presented to little Albert that resulted in that response of fear? He didn't have to learn it. So the unconditioned stimulus is something that naturally causes that response or that fear. The conditioned response is the result of a stimulus that little Albert had to learn to fear. So it was initially neutral. So the unconditioned stimulus in Watson's experiment was the loud noise, which resulted in fear. Then that loud noise was repeatedly paired with something that was initially neutral and that later became learned, the white rat. So again, in classical conditioning, you want to check your work. The two responses are going to be the same or similar, and they have to be involuntary. And the neutral stimulus and the conditioned stimulus, if learning occurred, again, will be the same. So now think about this in the real world. How might classical conditioning explain how a person could develop a phobia of dogs? Just the way little Albert developed a phobia of a white rat. And remember your hint, fill in the responses first, and they will be involuntary and the same or similar. So basically a real world example parallels Watson's experiments exactly. So the unconditioned stimulus might be the actual dog bite, right? That you don't have to learn to be afraid of that. But a neutral stimulus, because it was paired with the dog bite, potentially paired more than once, seeing the dog could then result in the same fear response. So you can see how behaviorism is explaining phobias as being potentially created as a result of classical conditioning. Certainly there's other ways to obtain phobias, including maybe observational learning. Then we can go back to operant conditioning. So operant conditioning might be an explanation as to why a fear of dogs that was obtained through that classical conditioning process continues. So this is kind of a formula for operant conditioning. You have a stimulus, so something in the environment. There's a voluntary behavior. The organism makes a choice, does something. The operant consequence, that's where you fit in those terms, where it's positive reinforcement, negative reinforcement, positive punishment, negative punishment. And then you have a future behavior. So anytime a behavior is reinforced, whether it's positive or negative, that behavior will increase in the future. If the operant consequence is a punishment of either kind, that behavior will decrease in the future. If there's no change in future behavior, then you don't have learning. So if you have an individual with a classically conditioned fear of dogs, that might actually continue and persist and not become extinct, because when they see a dog, here's your voluntary behavior, walk away. So the sight of the dog is causing anxiety. They walk away, and the consequence is a negative reinforcement, the removal of that anxiety. So in the future, when they see a dog, they're going to walk away. So they're never going to address that phobia. Now, if we look at anxiety disorders from a humanistic approach, you're going to have to think here a little bit about what you learned about Maslow and Rogers in the personality unit, and think about how, if one's needs weren't met, how that might explain anxiety disorders. So here we have three possible answers with the humanistic approach. Again, you want to think about Maslow or Rogers. So the first two samples here are both related to the theory of Carl Rogers. Carl Rogers said that for people to be kind of the best version of themselves, that one of the requirements would be unconditional positive regard from someone in their life. That would mean support that was there even when you were making mistakes, right? He also talked a lot about the need for a congruent self-concept, like your sense of who you are as a person and reality should be largely similar, like overlapping or congruent. And a lack of congruence might cause anxiety. And finally, at the bottom, you have a Maslow answer. So the cause of anxiety disorders might be that a person's lower needs on the pyramid were not met, right? So the bottom of Maslow's pyramid, as you recall, is physiological needs. Then you have safety, then you have belongingness, esteem, and then at the top of the pyramid, self-actualization. If you're looking at the cognitive approach to explaining anxiety disorder, the cognitive approach would say that behaviors and mental processes, these are the results of thoughts that people have, memories, problem solving. So anxiety disorders might be, in this case, a consequence of, dysfunctional or maladaptive, unrealistic thoughts. The biological approach, as we mentioned earlier, might talk about anxiety disorders from differences in the brain. This could be differences in neurotransmitters. It could also be the result of a genetic tendency. Evolutionary approach is based on Darwin's theories, and it would say that anxiety disorders are the consequence of extreme versions maybe of behaviors that gave early humans a survival or reproductive advantage. So while anxiety disorders are not helpful to anyone, anxiety itself, like the state of being anxious, did provide potentially early humans with a survival advantage because it caused them to pause and not take part in things that might be dangerous. So a little bit of anxiety causes, maybe protection. And the sociocultural approach would explain that anxiety disorders are influenced by norms. So norms are kind of accepted behaviors and beliefs that are associated with like your culture, your ethnicity, your gender, other groups that you belong to. And this approach, this theoretical perspective, allows you to understand that although anxiety disorders exist across cultures, some disorders might be more cultural specific, or you might have differences in prevalence due to group norms or differences in how people report anxiety. Are they reporting it in terms of thoughts, right? Thought processes and worry and anxiety, or are they simply reporting, focusing maybe more on physical symptoms like heart racing or difficulty with fast breathing? Okay, now just kind of a theoretical question. What approach do you feel offers the best explanation of anxiety disorders? So if you wanted to explain the cause or the etiology of phobias, is Freud's answer the best? Is the biological perspective correct? Is it cognitive? Which do you think is the best? If you're having trouble deciding, that might be that you are looking at something we call the biopsychosocial approach. And modern psychology combines approaches to create the best description. So something like anxiety might be partially related to genetic predispositions. It could be related to neurotransmitter imbalances, but it could also be related to those irrational negative thought processes as well. So when you look at biopsychosocial and you break it down, you can cover all 7 modern perspectives. So bio would include your biological and evolutionary. The psych would include cognitive, behavioral, humanistic, and psychoanalytic or psychodynamic. And then the social would be the sociocultural perspective. This biopsychosocial approach is evident in the DSM-5, which also includes etiology from many of these different perspectives and includes specific sections that are related to culture. When we're talking about explaining mental illnesses from the 7 perspectives. There's also this idea of the Diathesis-Stress model. So this is saying that disorders are the result of an interaction of a predisposition, so a tendency that's already there, a biological, like a genetic cause or something in early childhood, and then it's combined with stressful life events. So it's the combination that might result in the display of the disorder. So if you look at something like schizophrenia and they study that it's highly heritable, and you have identical twins, monozygotic twins with 100% the same genes. If one individual develops schizophrenia, then the other twin has only a 50% chance, not a 100% chance. So there is an environmental piece. The diathesis-stress model, just kind of want to point it out here a little bit, is often discussed in terms of schizophrenia, but it applies to other mental illnesses and other mental conditions. And research in this model has helped identify both key stressors and also key preventive measures that can reduce the symptoms or the severity of a mental illness. And key protective factors might include things like psychopharmacology, medications, skill building, cognitive behavioral therapy, and certainly social supports. Okay, now we're going to stop here and check for understanding. I'm going to give you just a couple of quick examples, and let's see if you can identify the psychological perspective being identified or being expressed in each of these application examples. Sometimes it helps to, kind of look for those key psychological concepts or terms, maybe underline or highlight them, and see if that helps you to identify the correct perspective. So the first one, you should have seen humanistic, and you might have seen Maslow's theory in this example. Second one is biological. So this is a specific brain structure, the relay station of the thalamus. And cognitive would be unrealistic negative interpretations. I just want to highlight kind of a pretty famous study from 1973 by Rosenhan. So the participants in the study were Dr. Rosenhan himself and 7 others. And what they did is they showed up to psychiatric hospitals and attempted to get admitted. They all reported the same symptoms. They reported hearing auditory hallucinations, and they reported the same auditory hallucinations: thud, empty, hollow. They were all admitted, and after they were admitted, they had to, of course, be careful not to take any of the psychiatric medications that they were given, so they pretended to take those. And what this study was really about was how well were diagnostic methods at the time working. So this is 1973, so they're operating on the DSM-2. They were also looking at labels. If a person recovered, would they be labeled healthy or just forever labeled as formerly schizophrenic? So all of the patients were admitted with a diagnosis of schizophrenia, with the exception of one. I believe it was manic depressive, which is now called bipolar disorder. And the results were that pseudo patients just acted normally once they were there. But it took between 7 and 52 days before these participants were released, and they were all released with the diagnosis of schizophrenia in remission. And interesting is many of the patients in these psychiatric facilities were able to recognize that the participants in this study did not belong. So when we think about this study, it is almost 50 years old, but it is important because it really brought up this discussion about how reliable and valid is diagnosis, and it led to subsequent improvements in the DSM-5 and other methods of diagnosing mental illness. And it also drew a lot of attention to the problem of stigma, so that allows psychologists to work on ways to reduce stigma. Few extra things to consider about the Rosenhan study. If you want to take a look at these questions, and if you're interested in the study, it's fascinating study. There's a new book out by Susan Cain called The Great Pretender, and she takes an in-depth look into this study. She tracked down individuals involved in the original study, the ones that she could get a hold of, and reviewed the research materials and the research notes. So if you're interested in this really unique study and how it applies currently, you might want to look into that book by Susan Cain. Okay, we do have to go over a few more categories of disorders from the DSM-5. So we're going to do feeding and eating, substance and addictive, and personality. This is a very broad overview, so I would encourage you to review your text and look for more information. Feeding and eating disorders are a category of disturbed eating, and you're going to see here that these behaviors are distressing and dysfunctional. Anorexia nervosa is food refusal, fear of weight gain. These people typically excessive weight loss measures, very distorted body image, below normal body weight. Bulimia nervosa is characterized by binging, which is periods of excessive overeating, and those are followed by purging, right? So vomiting or other measures to remove or reduce the intake. And binge eating disorder is periods of extreme overeating, kind of those binge periods, but with the absence of purging behaviors. Substance use and addictive disorders. These are actually in the CED, they're in the course description for Unit 2. So this is something that's located both here and in another unit. So you're going to want to spend a little bit more time on substance use disorders. So substance use disorders can involve the use of alcohol or other drugs, and it has to disrupt daily functioning, right? And so you have these kind of 4 broad indicator categories. So if somebody's use is resulting in diminished control, they might be using more for longer. They might have repeated failed attempts to reduce or control their use. Diminished social functioning means that the use has disrupted their ability to care about their regular life. So this is that dysfunctional piece. Maybe it's preventing them from work or school or being able to manage home life or social relationships. Hazardous use would be continuing to use despite maybe medical problems, or this would be driving under the influence. And the last category, drug action, is the biological piece. So they may have developed tolerance, needing more and more of a drug to get the same effect, or withdrawal, like the physical and psychological pain that occurs after use. Just want to reference a couple terms. Substance use disorders have a high rate of comorbidity. So many individuals have 2 or more disorders at the same time, and that's what comorbidity is. And substance use disorders are often comorbid conditions with other conditions. So psychologists and psychiatrists treating individuals have to help the individual both with maybe their depression or bipolar disorder, but also a substance use disorder as well. The 2 main relevant neurotransmitters are probably dopamine and endorphins. So dopamine is part of the pleasure circuit. So a drug like cocaine, for example, works in part by blocking the reuptake of dopamine, thus flooding kind of the system and creating this pleasurable effect. Morphine and heroin are also agonist drugs because they increase not only dopamine, but also endorphins. And so that mimics the effects of endorphins. Some addictive substances also work with serotonin and other neurotransmitters as well. But remember, these are drugs. So the substance cocaine is an agonist for the neurotransmitter dopamine. Personality disorders, these are long-lasting patterns, and there are many, many more. I just put 3 up today. So antisocial personality disorder involves individuals who consistently violate the rights of others. They often are impulsive, ruthless, and lack a conscience. Avoidant personality, on the other hand, are individuals who are excessively shy in social situations, very afraid of being evaluated negatively. So sometimes these two get confused. Oftentimes in common language, we use the term antisocial if someone is not wanting to participate in activities. But to psychology, that would be really being avoidant. And finally, we have borderline personality disorder. These are people who have difficulty with relationships and a kind of highly unstable moods, self-image, lots of impulsiveness, tendency towards potentially self-destructive behaviors. And like I said, there are many more examples of personality disorders that you can research later. Okay, just a quick introduction today into treatment, and we're going to talk about treatment more in tomorrow's lesson. But I want to start with mental health professionals, kind of separating these out. So first of all, you have a psychiatrist, and they're unique because they have a medical degree. So this means that they are able to prescribe medications, and they also may utilize psychotherapy. So an individual with schizophrenia might see a psychiatrist for medication management and potentially therapy, but they might also see someone like a clinical psychologist who specializes in diagnosing and treating mental illnesses. These individuals, these professionals typically have a doctoral degree as well, and they work often in collaboratively with other medical professionals helping individuals. Most clinical psychologists are treatment providers. They work with patients, but some of them actually do basic and applied research as well. A counseling psychologist is also a doctoral degree, and these individuals would work with people who are dealing with everyday adjustment issues. This could be marriage or social or career concerns. They might, however, also work with individuals that have diagnoses like depression or anxiety as well. A psychoanalyst is a special term for a therapist that uses the methods and theories based on Freud's original theories of psychoanalysis. There are also licensed professional counselors and licensed professional social workers, and these are mental health professionals that might have a master's degree or they might have a doctoral degree, but they also work with helping individuals in terms of treatment and coping. Regardless of the mental health professional that you're looking at, there's kind of like some central overall ideas about therapy and intervention. So one of them is that, of course, the relationship is confidential between the client and the therapist. A therapist is going to have an approach or maybe a combination of approaches for how they focus on causes and treatment. And they are, of course, subject to ethical guidelines. A little bit about psychology and the law, since we brought up confidentiality. This is an ethical duty of a therapist to keep the client's information and what happens in therapy sessions private, safe. And this is required both by law, state and federal law, and also by the professional guidelines of organizations like the American Psychological Association. And there are only a couple real exceptions where therapists are allowed to break confidentiality. One, of course, would be with client permission, and the other one is a little more nuanced. This is if they are compelled to break confidentiality if the client or others are in danger of serious harm. Another place where psychology interacts with the law is this idea of insanity versus competency. So these are both legal terms, not really psychological terms. And the method for determining insanity has to mean, like, if he or she knew at the time of the crime, not, maybe months or years later in the courtroom, was capable of knowing right from wrong. And competency is more about, can this individual, are they capable of understanding what's happening in the moment during trial? Can they be a defendant? Can they serve as a witness? And despite public misconceptions, the insanity defense is not something that's used much, especially in very serious charges. It's rarely effective in terms of really serious crimes, but it is sometimes used in like misdemeanor situations. So in Unit 1, we talked about a variety of professionals, and this is where forensic psychologists and psychiatrists would fit in. One of the aspects of their job might be determining if an accused individual meets the criteria for insanity at the time of the crime and evaluating their capability of participating in a trial. Okay, there's the therapy methods also align with those approaches or perspectives. And we're going to talk a little bit about these individuals tomorrow. But today I just want to focus on two of the names here I highlighted for you in blue in behaviorism therapy, because these names also are related to their theories, at least to the learning units and material that you will need to know for the exam. So Mary Cover Jones is someone who's considered to be the first behavioral therapist. So she took Watson's research and basically flipped it. So if you can use classical conditioning to create a phobia, such as what's happened with little Albert, you can use classical conditioning to eliminate a phobia. So with her participant named Little Peter, he had a conditioned response of fear to a rabbit, right? And Mary Cover Jones is going to use what we call exposure therapy by introducing a new kind of unconditioned stimulus, cookies, that creates an unlearned relaxation response. And then by pairing that new stimulus with the rabbit, that rabbit fear bond will be replaced with rabbit relaxation. So this is kind of like the first example of behavioral therapy. Another important behavioral therapy is this idea of systematic desensitization, which was developed by Joseph Wolpe. This is a way to gradually reduce the reaction, right? So if you have someone who is afraid of heights or afraid of flying in a plane or afraid of flying or afraid of spiders, that would allow them to slowly replace that bond with, instead of flying and fear or spiders and fear, with spiders and relaxation. And maybe you remember from the bio unit aspects of the peripheral nervous system. We have the sympathetic nervous system. These are both part of the autonomic nervous system, which is your fight or flight response, and the parasympathetic, which is what we like to call as rest and digest, your calming system. And what Wolpe said, his argument was that these are incompatible. You cannot simultaneously be anxious and relaxed. It's kind of an either or. So he's going to replace that feeling of fear, which is a sympathetic nervous system reaction, with a parasympathetic one with relaxation. And it's a three-step process. So you would first have the client create a hierarchy of fear, right? So maybe the scariest thing on the hierarchy would be long distance flight. And maybe the beginning of the hierarchy might be just looking at a picture of a plane or driving past an airport. And they're going to create kind of progressively more stressful versions of this fear. Then they're going to teach the person relaxation methods, right? So very specific breathing and even, thought methods to cognitive methods to help you relax. And then the patients would gradually work through the hierarchy, starting at the easiest step, slowly working their way up to potentially being able to get on an airplane. Okay, so to sum up for today, we did talk a lot about the psychological perspectives or approaches and how they apply to the causes of mental illnesses, but psychology is about explaining behaviors and mental processes. So this would apply to any behavior, not just disorders. Then we talked really briefly about a couple more categories of mental illness, and then we introduced treatment and talked a little bit about behavior therapy, which is something that would also be a part of your learning unit. So for tomorrow, I'm going to give you a little bit more AP exam practice. I'm going to give you a little bit longer FRQ. So I'm going to leave this up on the screen a little bit, but I want you to take a look at this mini FRQ, use SODAS, and write this out. You can type it out, handwrite it, whatever you prefer. And we're going to start first thing tomorrow by going step by step through this exam practice. I chose practice terms for this one from the biological basis of behavior units. with a connection somewhat to anxiety and Unit 8, which we talked about today. So your terms are GABA, systematic desensitization, and the sympathetic nervous system. Make sure that you pay attention to the specific directions when you go to apply. So for terms in Part A, you want these things to help Danny succeed. And in Part B, this might be something that would hinder him. Next up, I have a little notification from the College Board. The College Board is working hard to make sure they can provide technology solutions for as many students as they can taking these exams at home. The College Board has asked me to give you access to this survey if you need help finding a tech solution. The hope is that we can reach students watching on phones, shared devices, et cetera, and offer them a more effective solution, help you be prepared for the at-home exam this year. So please do not hesitate to reach out and take a part in this survey. Okay, thanks so much for watching, and I hope you will join us again in the future. Make sure you work on that practice FRQ, and I will see you tomorrow.